Dr. Luke Bergman. We're so excited to host you today and talk about the wealth of experience and insights that you've gained from your work in leadership for behavioral healthcare systems. And you came from New York, and then you brought that experience into California systems, which makes you have a really unique perspective that I'm interested in getting to dig in a little further about.
Right.
But first, before we talk about policy, I would like to know just a little bit about who you are,
Mm.
what motivates you personally, and why have you dedicated so much of your life to behavioral health?
Thank you so much for having me, first of all. It's a real pleasure and an honor to be here. I think, like a lot of people who work in behavioral health, I came into this field with a lot of familial experience with behavioral health issues that have sort of, you know, um, motivated me throughout and been, I think, really important touch points, especially, during sometimes protracted moments when things have gotten especially frustrating or difficult. Um, I have family, close family, with sort of different combinations of substance use disorder and of mental illness, including serious mental illness. Um, and so, I have understood behavioral health concerns to be really significant parts of people's lives, of everybody's
Mm,
lives, um, and to be really important, significant parts of health, more specifically. And as I've sort of entered this field, one of the kind of like uh, remarkable, I think, aspects of this work that confronts a lot of people when they first come into it is that we've got not just systems that seem sometimes at odds with people's experience. We've got like, specific institutions
mhm,
sometimes that seem unsure of how they should be apprehending people. Um, and for me, as I sort of have gotten further and further into things, and really, again, informed by this deep experiential, kind of understanding, um, that has just like been incredibly motivating, right? That we've
mm,
got huge brick and mortar institutions that don't understand their most basic charge in the world.
mm.
Uh, I feel like there's just so much to do. There's so much to fix. So it feels very, very motivating. It's very gratifying to do this kind of work for me.
But it sounds like you remain hopeful if you
Oh, I
say
do. Oh,
gratitude.
I
Yes.
do. I do. Yeah, I would say in the face of um, a lot of exhaustion, I think, among people who do this work. Sometimes some like well-earned cynicism among people who do this work. Um, no, I do remain, even in this current moment, right,
Mhm.
where we've got a federal administration that, a few days ago wiped out $2 billion worth of really important programmatic grants addressing substance use and mental health, reinstated it, I guess, the next day.
Oh,
Um, right, so things are really sort of whiplashy in the policy environment, and I think have given a lot of people. Um, uh, Greater challenges sustaining a sense of hope maybe than they have had. I feel like, frankly, so many of the answers to what feel like the most vexing challenges in this work are very commonsensical.
hmm.
And that if we can kind of learn to sort of bracket our prejudices and learn in some cases to question um, the sort of like taken for granted truths of like kind of how behavioral health is supposed to work, what its relationship to the rest of the healthcare system is or should be. If we bracket all of that stuff and just sort of think about this with our most simple, in a way, our most kind of like naive
Yeah.
mind, the answers are not terribly complicated.
Yeah. Can
And
you give me an example of that? Like the
oh
commonsensical
yeah,
thing.
um, I mean, I actually have recently had, I would say, a traumatizing experience that is right at the nexus of me as a professional and me as a person, that I think reflects in a way, the abandonment of common sense
Mm.
in the work um, that we do in this country in particular, that I really sort of carry as intense motivation around this question. And so that circumstance has to do with my stepfather, uh, who really raised me from when I was about a year old, and who died this past
Oh,
May.
so
Thank you. And he passed away, I would say, primarily as a result of psychiatric illness.
oh.
He was somebody who struggled with substance use disorder the entirety of his life. It was like very much a part of our familial dynamic, right? There are real sort of familial structures that get sort of embroiled into substance use disorder in family settings. Um, uh, and he had anxiety disorder. There was a strong relationship between his substance use and his anxiety
Mhm.
issues, of course. This is very common. Um, as he got older, through his 70s, particularly into his late 70s, his anxiety disorder got much worse,
Mm.
much more profound. He suffered from a panic disorder that was really like disabling for him um, for long stretches. I mean, this is a person who's really brilliant, um, sophisticated. Founded a small business, a manufacturing company, and ran it for years and years very successfully. Could manage a great deal of like circumstantial and logistical complexity, and who found himself overwhelmed with like the simplest thing, right? Overwhelmed with the thought of having to go to the store to buy groceries, that sort of thing. Really incapacitated by his anxiety. It turned into, or sort of, I think kind of became oriented significantly to his own health. So he developed health anxiety, like the most profound health anxiety, which ultimately led to him um, not eating. He was a
Mm.
person who was like carried about 210 pounds through most of his life. Um, in the last year of his life, he went down to about 135 pounds. He lives in northern San Diego County. During this time, I was the director of behavioral health for San Diego County,
Okay.
right? Which
Yeah.
is a big job overseeing basically, the public insurance system, but also the public conservator's office. I was the designated public conservator in San Diego. It would be my jurisdiction in that position to set policy around or ensure conformance of kind of local practice with state policy around like involuntary holds and transports for care, right? It was up to me to decide this person's not taking care of him or herself. They need to be against their own intention taken into care. I knew that he wasn't doing well through the last year of his life, and I would talk with my mom a lot
Yeah.
about like, I'm the public conservator. It's kind of my jurisdiction to like across this whole county make decisions about transporting people just like this, and I
Mm.
think we got to talk about doing that. My mom sort of couldn't you know couldn't really digest that possibility, so we
Mhm.
we didn't um, we didn't take him in against his intention until um, until in fact the day I resigned from that position, and sort of had bandwidth, frankly, to really see him, and the full sort of state of things with him. But before then, I had found a doctor that I thought was like, this is to get back to the sort of practical, sort of solutions to complex problems that we were teeing up. I had found this doctor who was board certified in family medicine and board certified in psychiatry. Somebody who really had deep capacity right at the nexus of, the most significant division in American healthcare. And I knew that's the kind of capacity that this person needs, right?
Mhm.
Really serious psychiatric issues, and also, that are related to his physical health. And so I set up an appointment at this clinic. It was a FQHC, a federally qualified health center. And my stepdad went, and I, like, with every assurance from me, you are going to meet a doctor who is not going to pigeonhole you into a, sort of a set of psychiatric concerns on one hand, or a set of physical health care concerns on the other. Um, and so he went to his appointment and discovered that the appointment he had gone to was, in fact, only a psychiatric evaluation.
Mhm.
and that he would go for a subsequent appointment for only a physical health care evaluation. And
Right.
why is that?
Huh.
That's because there is policy in the state of California that prohibits same-day visits and reimbursement for
Really?
a behavioral health visit and a
Oh
physical
my
health care
goodness.
visit.
Yeah.
Even though we all recognize, right, that we are, I mean, any of us, right, but any of us, my 4-year-old can speak coherently to the fact that she is emotional and she is physical and those things
Yeah.
are part of the same person. Even though we all can pretty easily recognize that, we've got this core aspect of our system. Our community health clinics will not enable people to engage with them, coming forward with a sense of the connection between their
Yeah.
physical
Oh
health
my
and their
gosh.
behavioral health.
Yeah.
So he didn't want a psychiatric eval. So he didn't go back. He disengaged from care and he continued to deteriorate. And I
Oh.
really do feel, really genuinely, that like that discordance
Yeah.
and the absence of just like the most commonsensical policy wisdom contributed to his death,
Wow.
for example.
Yeah. Yeah. That's that's quite the example. Yeah. So you've experienced that.
Oh yeah,
And but
yeah.
you knew what that meant or, from a policy perspective. But how does that inform you moving forward, that experience?
Well, deeply actually. So I left being director of behavioral health at the county, and I work at actually the nation's largest like devoted health consulting firm now, which is called Health Management Associates. Um, and one of the things I've been sort of working hardest on, I've had many calls just this morning about this, is bringing county behavioral health and community clinics into the same space and figuring out how to get them to work together so that
Huh.
there is policy that actually incentivizes them to do that. And I mean, when I say policy, ultimately in like, the state of neoliberal American healthcare, when I say policy, I mostly mean money. Most of what happens in American healthcare happens because it's motivated by money. For those of us who have worked at high levels in healthcare policy, like we know it's ultimately intuitive that like you think about money not in terms of simply its kind of quantity or its absence, but you think about it in terms of what it incentivizes
Mhm.
a healthcare practitioner to do or not to do. Every cent in healthcare is meant to either incentivize a behavior or disincentivize a behavior.
Yeah.
And right now, the money disincentivizes wise, caring clinicians, beautiful people doing beautiful work from doing the most commonsensical things. And so this is, that's been fascinating so what we've been doing is convening community clinic leadership. We've been convening county behavioral health leadership across the state and just having them begin to sort of voice their concerns about working with one
Yeah.
another.
Uh-huh.
And the misunderstandings are just like massive. The
Interesting.
lack of familiarity with sort of the most basic mechanisms in work in those two settings is just um, it's really remarkable.
Mhm.
And I have to say, so my experience of trying to actually, and this is work that's very motivated by my experience with my stepdad, like very directly. I sort of came into this job and I was like, well, if I get to do what I want to do, I got to fix this community clinic behavioral health problem that just killed my stepdad. And so, I've been highly motivated to,
Yeah.
to bring these parties together, and um, and it's been arduous.
That's what I was gonna ask. How's it
Yes, it
going?
has been. It's going well. It's I mean, and we're sort of like cultivating interest and nurturing, I think, a lot of activity in this space. Um, I can say a little bit, kind of specifically about why I think, because it's not just because I sound super compelling, even though your audience will agree I sound super compelling. Um, it's not just that I'm like motivated by a deep sense of urgency about it. What's keeping people at the table is money. It's the myriad questions about money
Hmm.
And, um, so I would say it's challenging just to get them to listen,
Huh.
just to get these two parties to learn about this, the kind of policy and reimbursement landscape in one
Yeah.
setting
Yeah.
and have that party learn about the other setting. Community clinics are paid through a mechanism called PPS. County behavioral health pays for things through a mechanism called fee for service.
Mhm.
Those two things don't necessarily work well together.
Mhm.
Um, and they're just very different and they're unknown each to the other.
Mhm.
So a lot of what we've been doing initially is just like developing greater fluency across
Yeah.
those two spaces. Um,
And then
and
how do you even get them to take the time to talk with each other?
well,
Like, because 'cause
we
they're busy.
yeah, they are very busy and particularly busy in this particular moment um, because of deliberately contrived policy-driven crises, I would say, on both sides, right? So it's like we're having multiple crises in healthcare, and that is what's motivating these parties to come to the table right now. HR1, federal policy with which you may be familiar, it, has the potential to really dramatically gut the Medicaid program across the country because it's creating work requirements for, for folks who have been on Medicaid for, and who rely on Medicaid for health insurance. Now they have to demonstrate that they are gainfully employed if they have certain levels of income. Um, they have to renew their eligibility in Medicaid more frequently than they used to. Um, Part of what that means, because all of that happens through a very deeply imperfect bureaucracy, a lot of what that inevitably means is that there's going to be a massive loss in Medicaid enrollment simply because of the bureaucratic inefficiency, simply because it will be too hard for states that run their own Medicaid programs to accurately track who is employed up to sort of sufficient sort of percentages of what would be full-time employment. Because as people are required to renew, they won't for whatever reason because it's a pain because they're not able to get out of work and go to they're not able to get onto the portal. They don't
Yeah.
have Wi-Fi, whatever it is, right? We anticipate. I mean, in California alone, the Department of Healthcare Services is estimating a loss on the Medi-Cal rolls of around 3.5 million people.
Hmm.
And for federally qualified health centers that primarily treat people who are in the Medicaid program in California, Medi-Cal, and who only come to those clinics because they have that insurance, when they're not on that insurance anymore, they're either not going to come, right? And so that will be lost business for the community health clinics. They're either not going to come or they're going to come and not have any insurance. And so the
Yeah.
FQHCs will have to take care of them without any reimbursement.
Oh.
So we're in a moment right now when the network of community clinics, that's the primary mechanism for people on public insurance to have access to primary care. We are in a moment right now when virtually every federally qualified health clinic in the state feels under existential threat. They feel like they don't know if they're going to make it. And that happens to concur with a moment in county behavioral health land, right? So counties run the Medi-Cal plans for people with substance use disorder, which is like the most common chronic illness in the country, and also for people with serious mental illness. Meanwhile, in county behavioral health land, recent policy has shifted an emphasis on addressing people with chronic homelessness. So counties are having to shift huge percentages of their overall budgets just to focus on people with chronic homelessness.
Oh, interesting.
What that means is that they're not going to be able to care for people who are even unstably housed or people who are housed but poor and and part of our public insurance system. So counties are in a state of crisis. What do they do with that population, right? What do they do? That's their crisis. FQs are, we need people on Medi-Cal
Yeah.
in order to stay afloat. Well, a technical aspect of HR1, this sort of egregious federal policy, is that people with behavioral health conditions are less likely to lose their Medicaid enrollment. So
Huh.
there's a real opportunity for behavioral health because, behavioral health people are not going to lose their insurance as easily. Counties can navigate those people towards FQs. FQs will embrace them because they're
Mm.
looking for people on Medicaid. I I feel like, and because there's perennial conversation about how we have to do more integrated care. Primary care needs to do more to integrate behavioral health and psychiatry into the work that they do, et cetera. It doesn't happen at the scale that it should. It doesn't happen with the speed that we would want it to because it isn't getting paid for. Because the
Mm.
parties at play don't see sufficient monetary motivation. Well, in this world between county behavioral health and federally qualified health centers right now, there's a lot of motivation on both sides. They're sort of these twin crises. The challenge for me right now is to sort of like use those crises to pull folks together, to get them to work out what the kind of basic clinical operational issues are, to understand that they should be motivated by the bottom line to participate in this conversation, and then to start doing it. And
Yeah.
if we can move behavioral health care into the FQs in this moment of crisis, I think we'll have an opportunity not just to sort of weave these two institutions together, but to actually like model the effectiveness of more integrated care generally. We do need to address policies like the one that made it difficult for my stepdad to get care, right? We do need to address like this prohibition against same-day billing and some other
Yeah.
sort of like, low-hanging policy fruit. But yeah, we're in a really difficult moment. But things like I'm just describing, part of what give me a lot of hope, part of what sort of keep me energized.
Yeah. Well, it's interesting that you've kind of found a way to find the struggles in both of these organizations and make it beneficial for
Yeah,
them to come together.
yeah.
That's pretty great.
It is
Honestly.
kind of great. It is sort. It's like one of
Yeah,
these very right.
good.
People say, "Oh, it's a win-win all the time," even though it's clearly like just a win on one side very often. But this is a case where I really feel like um, y'all may not believe it, but you really stand to gain, like
Yeah.
in the immediate term,
Yeah.
and you can build a sort of firmament on which we can continue to build out more integrated care opportunities. Um, it again, it's like this sort of gets back to your introduction of me as coming from outside of California, right? Like probably the most stubborn parties in the conversation are county behavioral health leaders, right? And so that's my tribe
Mhm.
that I'm kind of most recently coming from. Um, but most folks who are, kind of in bureaucratic leadership in California behavioral health, California County Behavioral Health, they are people who have grown up as professionals in that institutional setting. They only know that.
Mhm.
Um, and in a state of sort of resource shortages everywhere, there's nothing that gets emphasized more in county behavioral health than just like protecting the money,
Mm.
right? We got to protect our resources for our people. That disincentivizes like the institutions that have the most workforce expertise in behavioral health, right? That are like best situated politically to kind of make innovative things happen. That disincentivizes them from leaning in to this kind of collaboration traditionally. Um, I think part of what informs my, like my determination about it, or like, I suppose, and my optimism about it is that I come from outside California. And I've like seen this kind of thing
Yeah.
work really beautifully in other jurisdictions.
So you know it's possible.
Totally,
Yeah.
totally.
Yeah. So can you talk a little bit more about integrating primary care with behavioral health?
Yeah,
You mentioned before
yeah,
about primary care, behavioral health being able to learn more from primary care.
yeah,
Tell
yeah,
me more about
yeah,
that.
yeah. Well, I think I'll refer actually to a lot of work that I was involved in New York and describing that. I mean, I think the most important thing um, that primary care I think has really developed over the last decades in particular is is an attunement to chronic illness, right? Like primary care understands that it needs to be focusing on, on the set of like some very common somatic chronic illnesses, and the primary care practices have developed really effective registries and means for, assessing how people are doing over time um, with respect to risk and management and prevention, right? Primary care practices are hinged at this point, in this day and age, to doing upstream work. Behavioral health needs to understand that and needs to make a shift in the same direction. Right now, just sort of in terms of, the culture of the work, behavioral health is obsessed with the idea of the crisis,
Mm.
right? Primary care is all about normalcy. It's all about sort of consistency. It's about cadence of contact.
Mm.
It's about tracking metrics continuously over time, about, managing risk continuously over time. Behavioral and primary care doesn't really use the word crisis. In fact, no domain in healthcare uses the word crisis except for behavioral health.
Really?
We talk about critical care, intensive care, emergency care. In behavioral health, you don't see a word more frequently used than
Oh
crisis.
my gosh.
Um,
I didn't
oh,
realize that,
that's
but you're
totally a
right,
thing.
correct.
It's
Yeah.
totally a thing.
Yeah.
And it's even like written into a lot of the regulatory structures that determine the kinds of work that happen. So crisis stabilization units or like
Crisis response
mobile
and
crisis response teams,
yeah.
right? These are things that
Crisis helpline.
crisis helpline, right? Like the things that have gotten the most attention, I would say, in terms of policy and in terms of resources, seem often to have that word in them.
Mhm.
Um, and and I think like that's not an accident. It's not just sort of a
Gets people
meaningless
attention.
coincidence. It gets people's attention.
Yeah.
It's sort of their politics that drive it. There's a whole kind of morality around it, I think, even,
Yeah.
right? What a crisis. I mean, in a way, it's like it's the direct antithesis of what primary care is about. Crisis means like derivation from the norm, right? Crisis means this is not normal, right? Things
Oh
have
my
like
gosh, yeah, that's
thing,
such a good point.
things are
This is
this is
terrible.
this is
Yeah, this is
it's not normal. It's not,
yeah,
I mean,
uh-huh.
and I would really emphasize that, right?
Yeah.
Because people who struggle with behavioral health conditions are thought of culturally as not normal. Like
Mhm.
primarily, that's
Mhm.
the sort of valence that we take to thinking about them,
Yeah.
and the care that we give them. Um, perpetuates that because it really lionizes this notion of the crisis, and
Yeah.
all of our investments go into crisis, and all of our
Yeah.
policy drives us toward thinking more about crisis instead of about chronicity. Um, one of the things
What
that
would you rename it? What terminology would you like
I would
to
probably, I mean, and I actually did this in San Diego. I was like, from now on, everybody, and I've looked across
says
my
I.
my my many staff. Well,
Yes,
when you
yeah.
run a big thing, you
Yeah,
get to
you
do
get to
this.
do that.
I was
Yep.
like, from now on, we're talking about behavioral health as a chronic condition,
Okay.
and and we're gonna do something here. We're gonna use a chronic disease model
Okay.
to sort of imagine how it is that we should be addressing even the most serious uh, mental illness. Um, I have to say, my staff, many of them who had worked, I mean, who were like amazing clinicians and had worked in county behavioral health for a long time, were more than a little upset, many of
Huh.
them, with that move on my part because it was, in their eyes, it was making behavioral health care less special in a way.
Huh.
It was sort of, it was reducing the sense of urgency
Mhm.
around behavioral health care. Um, and I get that. And I get that there's, a lot of value in, for example, the language around recovery as opposed to, chronicity. Um, and that the word crisis is like used to some extent to good effect with respect to drawing more resources in. But we have got to make this shift, right? We are obsessed with this idea of crisis. We are thinking about, the investments that we make mostly in terms of like momentary intervention,
Yeah.
followed by potentially episodic
Yeah.
engagement in care, depending on how like in or out of crisis a person is, right?
Mm.
There are still, for-profit inpatient psychiatric hospitals that are like looking for opportunities to continue to expand their facility footprints, that hither and nigh, that like there is an intense need, right? There is need and demand for more inpatient psych beds. We got to respond to that need for more inpatient psych beds. Inpatient psych beds are not therapeutic spaces.
No.
Inpatient psych beds are places where you keep someone for killing themselves until you can get them into a therapeutic space. That is really what they're designed for.
Yeah.
Um, but they're also like, the sort of dollars and cents kind of, profit potential model in inpatient psych is very simple
Mm.
and it's very difficult to resist,
Yeah.
right? It's driven by basically an orientation to volume. You, it's like driven by the same things that drive the economic modeling of a motel chain, right? Like you just want to turn rooms, you want to get people in, um, and you want to keep your beds full.
Yeah. Yeah.
That kind of modeling means that these institutions, which are sort of like, the most prevalent instances of care, they're incentivized not to keep people well,
Yeah,
right?
that's not good. This
No.
is against the commonsensical.
It's against the commonsensical thing. Shouldn't we take an approach where we manage somebody who is, dealing with particularly acute symptoms, and we can call it a crisis if we need to, right? But so we're
Yeah.
managing a person who's particularly agitated or whatever, and our whole focus should be on navigating that person into ongoing continuous care,
Yeah.
because we know that's what chronic illness responds best to.
Right.
But right now, we've got institutions that are like, the primary populators of the, continua, not just in California, but across the whole country, that are directly motivated not to do that. They want repeat business.
Yeah. Yeah, there are businesses. Yeah.
And yeah,
So, and then what are your thoughts about the strategy of training up primary care physicians with psychiatry skills? How do you feel
I
that?
think that's a huge part of the answer, right?
Yeah.
Is to is to sort of like help people. I mean, this is very threatening to behavioral health as as like a
Interesting.
domain in healthcare, because it sort of feels like this is its bread and butter, right? Doing this work, doing it in these settings. So we've got to, kind of, I think, resolve those like, institutional territorial challenges. In my experience, we always have to foreground how primary care is not just like a piece of the answer, or like adjunctive to the solutions to the problem. It's like at the core of how it
Mm.
is that we need to address these issues. And when I was working back in New York, there were opportunities within the public hospital system. I was AVP over behavioral health for NYC Health and Hospitals there. We actually developed a clinic in Kings County Hospital, which is in Brooklyn. It's called an Article 28 clinic, which meant that it was not a behavioral health clinic. It was a primary care clinic staffed by not a single psychiatrist, but every patient there was somebody who's diagnosed with a serious mental illness.
Huh.
And so every patient there was getting like pretty serious like psychopharmacological care from a primary care physician, who was very oriented to doing whole person integrated care, had gotten training, right? Not board certified as
Yeah.
psychiatrists, primary care docs who had gotten some training, done some continuing ed, knew how to prescribe olanzapine or other, kind of antipsychotics, knew how to prescribe antidepressants, knew the kinds of things, frankly, that TNT is training people in how to approach. And we had amazing outcomes in that
Love
clinic.
that.
And it
That is
really,
so cool.
yeah, it was beautiful and
And it's
really,
de-stigmatizing too. I'm going to my
absolutely,
doctor.
totally going to your doctor. And I mean, it has that impact on the people who go to that kind of
Yeah.
clinic. It also has that impact on people who are working in more regulatorily siloed behavioral health, right? We actually had that clinic in our behavioral health building, and it did so much to just kind of like shift people's
Yeah.
orientation
Yeah.
from like, oh, we're hiding behind this regulatory wall, to like, oh, we're part of mainstream
Yeah.
healthcare.
I love that.
Yeah,
Well, thank you so much for sharing all of this. This has been
it's been my
amazing.
pleasure.
Is there any other like final thoughts you want to leave with us?
I just, would really encourage anybody who has great pleasure of watching this to share the hope that we've talked about.
Yeah.
It is mostly just about common sense. It's
Mm,
about recognizing that money is going to drive stuff in the United States, probably for the foreseeable future. Um, but we can figure out how to use that to our advantage, right? We can figure out how to create opportunities so that common sense in care gets paid for,
mhm.
real value in care gets paid for,
Mhm.
instead of just volume. And that's I think like the big challenge that we will face heading forward is
Yeah.
how do we how do we get what we pay for informed by a commonsensical approach to the work.
Well, we built the system. We
We can
can.
build it again. Totally.
That's right.
Totally. Yeah, so people want to be in conversation about this kind of opportunity, this way of thinking. Um, if people aren't put off by my like hypervigilance about it,
Yes.
um,
Your motivation,
my motivation
passion.
for it, um,
So if people want to engage in this conversation with you and get in contact with you, how might they do that?
feel free to reach out to me over email.
Okay.
My name is Luke Bergman. My email address is lbergman with two N's at healthmanagement.com.
Yeah, beautiful. Well, thank you so much for sharing your
Thank you,
insights. I
Autumn.
really appreciate it.
Thank you.